Hello everyone and welcome to our module on neuromuscular disorders. In this video we're going to talk about disorders that involve the neuromuscular junction. The neuromuscular junction is where a motor neuron meets a muscle fiber and can depolarize the muscle fiber and cause muscle contraction. And there are two classic neuromuscular junction disorders. The first one is myasthenia gravis, which is far more common, and the second one, which is much more rare, is the Lambert-Eaton myasthenic syndrome. And for both of these disorders, what you want to focus on is what's going on at the level of the neuromuscular junction. That is what they're going to test you on the Step 1 exam. So let's start by reviewing how a neuromuscular junction works. Shown on the screen here is my own drawing of a neuromuscular junction. This is a motor neuron here at the top, this is a muscle fiber at the bottom, and this is a synapse here in between the motor neuron and the muscle fiber. So when the motor neuron depolarizes and it reaches the end of the neuron, that will open calcium channels, which will allow calcium to rush into the neuron. Calcium will trigger the release of acetylcholine, which is stored in vesicles inside the motor neuron. That will lead to acetylcholine release into the synapse, where it will bind to nicotinic receptors, and that will lead to muscle depolarization and muscle contraction. There's an enzyme found in the synapse called acetylcholine esterase. It will in time break down acetylcholine, and that will lead to loss of this stimulation of the muscle fiber. And on this slide I've summarized the important points from that drawing. So presynapse is where you find the nerve terminal, the ending of a motor neuron. Depolarization of the nerve terminal leads to calcium influx, and that leads to release of acetylcholine vesicles. On the other side of the synapse, the postsynapse, you find the motor end plate. This is where acetylcholine binds to nicotinic receptors, and that leads to muscle depolarization and contraction. And then in time, acetylcholine is broken down by the enzyme acetylcholine esterase. So now we're going to talk about specific neuromuscular junction disorders, and these diseases are very easy to understand if you just know how a neuromuscular junction works. We'll start with myasthenia gravis, which is an autoimmune disease where antibodies are produced that block nicotinic acetylcholine receptors. Basically, the antibodies compete with acetylcholine for receptor binding, and this leads to muscle weakness. And so it should be very easy to understand that you can make a diagnosis of myasthenia gravis by testing for acetylcholine receptor antibodies. Let's talk about the clinical features of myasthenia gravis. The hallmark of this disorder is something known as muscle fatigability. If you repeatedly stimulate a nerve, it will release less acetylcholine with each additional depolarization. What this means is, in myasthenia gravis, if you ask the patient to perform a muscle maneuver over and over again, you will see the muscles weaken with use. So to understand this, you need to appreciate that when a motor neuron depolarizes, it releases a large amount of acetylcholine into the synaptic cleft. If you give it time to reaccumulate acetylcholine, it will again release a large amount of the neurotransmitter. However, if you depolarize the nerve again and again in rapid succession, you will see a little bit less acetylcholine with each additional depolarization. That's because the neuron doesn't have enough time to build up the acetylcholine levels. In a patient with myasthenia gravis, this will lead to marked weakening because some of the receptors are blocked by antibodies. So as you diminish the amount of acetylcholine, you diminish the amount of muscle contraction. You should also be aware that this disorder classically presents with eye problems like diplopia, which is blurry vision, and ptosis, which is drooping of the eyelid as shown on the screen here. The eye muscles are very small and they are very vulnerable to blockade of just a small amount of nicotinic receptors, and 50% of patients who present with myasthenia gravis present with complaints of blurry vision or a drooping eyelid. You can also sometimes see speech, chewing, or swallowing problems. These are bulbar symptoms related to the cranial nerves in the brainstem. Those nerves also innervate relatively small muscles in the jaw and neck, and therefore many patients present with these type of complaints. The treatment of myasthenia gravis in clinical practice is complex, but what they want you to know for your boards is that the mainstay of treatment is with acetylcholine esterase inhibitors. These are drugs like neostigmine, pyridostigmine, and edrophonium. All of these drugs decrease acetylcholine metabolism and therefore raise acetylcholine levels in the synapse. If we go back to this drawing, acetylcholine esterase breaks down acetylcholine. So if you inhibit it with a drug, this means that whatever acetylcholine is in the synapse will stick around longer, and this can improve symptoms in myasthenia gravis. The disorder is also treated with immunosuppressants because, as I told you before, it's an autoimmune disorder. But what they want you to know for step 1 is that the acetylcholine esterase inhibitors will help the symptoms of patients with this disease. Patients who have myasthenia gravis will sometimes present with a complaint of an exacerbation of their condition. Basically, they will say that they are getting weaker, and this can occur for two reasons. The first reason is that they are not taking a high enough dose of their acetylcholine esterase inhibitor. The second potential reason is something called cholinergic crisis. This means they are taking too much acetylcholine esterase inhibitor, too much medication, and there's so much acetylcholine in the synaptic cleft that the muscle has become refractory to acetylcholine. This is a phenomenon called cholinergic crisis. The way you can differentiate between these two causes is by doing something called the Tensilon test. Tensilon is the trade name for edrophonium, an acetylcholinesterase inhibitor, and edrophonium is short-acting, so you can administer it at the bedside and it will quickly boost the levels of acetylcholine in the synaptic cleft. If muscle function improves, this means that the patient needs a higher dose of their acetylcholine esterase inhibitor that they take chronically. However, if muscle function does not improve, it means that they are in a cholinergic crisis and you need to lower the dose. So this is sometimes done clinically, especially with patients who have a lot of eye problems that you can easily test clinically. You can administer a dose of edrophonium and see if the symptoms improve. If we go back to this drawing, there are two reasons for an exacerbation of myasthenia gravis. One is that there is not enough acetylcholine in the synaptic cleft. So if you give edrophonium and inhibit acetylcholinesterase, the levels will rise and the patient will get better. The other reason is that they are chronically exposed to very high levels of acetylcholine and the nicotinic receptors are no longer responding. In that case, when you inhibit acetylcholinesterase, you will see no change in symptoms. Now, you should be aware that the Tensilon test may lead to complications, and it's high yield for you to understand these for the Step 1 exam because all of these complications relate to the fact that edrophonium diffusely increases acetylcholine levels and therefore it generally activates the parasympathetic nervous system. So all of these complications are basic elements of the parasympathetic nervous system being turned on by edrophonium. So patients given the Tensilon test and edrophonium may begin to salivate, they may develop abdominal cramping from bowel stimulation, they may develop asthma from bronchoconstriction, and they can also develop bradycardia. You can basically think of myasthenia gravis as a disorder of the thymus, and that's because most patients have some thymic abnormality. About 85% have hyperplasia and about 15% have a thymoma. And this is important clinically because the myasthenia gravis usually resolves with thymectomy. And this is also important for your board exams because a key test in a patient who presents with new onset myasthenia gravis is imaging of the mediastinum, either a CAT scan or MRI, because you want to know whether or not there is a thymic abnormality. Moving on, now let's talk about the Lambert-Eaton myasthenic syndrome, or LEMS. This is also a disorder of the neuromuscular junction, just like myasthenia gravis, although it's much more rare. This disorder is a paraneoplastic syndrome that classically occurs in small cell lung cancer. In Lambert-Eaton, there are antibodies produced that are directed against presynaptic calcium channels, and when you block those channels, you prevent acetylcholine release. So in the case of Lambert-Eaton syndrome, the diagnosis is made by detecting VGCC antibodies, which are antibodies against voltage-gated calcium channels. Going back to this slide, in Lambert-Eaton syndrome, you have blockade of voltage-gated calcium channels. This means that when the neuron depolarizes, calcium cannot get inside to trigger the release of acetylcholine. Therefore, less acetylcholine is released and you have muscle weakness, similar to myasthenia gravis. Now, a couple of important distinctions between Lambert-Eaton and myasthenia gravis. Lambert-Eaton affects the presynapse. It affects the motor neuron before the synaptic cleft. Myasthenia gravis affects the postsynapse. In that disorder, there are antibodies blocking nicotinic receptors found on the other side of the synapse. This is an important distinction. It's a basic feature of the two disorders they'd like you to know for Step 1. The typical presentation of Lambert-Eaton is slow onset symmetric proximal muscle weakness. So this is a distinction from myasthenia gravis, which usually presents with eye symptoms. In Lambert-Eaton, it often presents with proximal muscle weakness. Now, this is the same symptom you can see in myositis. However, in myositis, there is inflammation of the muscles. So you see elevated CK levels, and patients usually have muscle pain or myalgias. In Lambert-Eaton syndrome, it's purely a nerve problem, so you will see normal CK levels and no muscle pain or myalgia. So what do you need your proximal muscles for? These are your muscles like your shoulders and your hips. So you need those to walk, to rise from a chair. You also need them to comb your hair, where you lift your arm over your head. So these are the types of things people will complain of when they have proximal muscle weakness. Another feature of Lambert-Eaton syndrome, and one that distinguishes it from myasthenia gravis, is the presence of autonomic dysfunction, and this is important for you to understand. So in Lambert-Eaton syndrome, the neuron has a problem getting calcium in. This leads to decreased acetylcholine release onto muscle fibers and muscle weakness, but it also leads to decreased acetylcholine release onto autonomic nervous system structures. You can't get this in myasthenia gravis because the problem is with the receptor on muscle tissue. All you can get is weakness in myasthenia gravis. In Lambert-Eaton syndrome, because nerves can't depolarize and release acetylcholine, you see muscle weakness problems, but you also see autonomic dysfunction. So classically, these patients complain of a dry mouth from less salivation. They can also get erectile dysfunction and constipation. and this is all from decreased acetylcholine release in autonomic nerves. If patients repeatedly use their muscles in Lambert-Eaton syndrome, this will improve their symptoms. This is the opposite of what happens in myasthenia gravis, where there's muscle fatigability. This is because if you keep depolarizing the neuron, you will eventually get more and more acetylcholine into the synaptic cleft, and whatever acetylcholine is there can work normally because there's no problem with blockade of nicotinic receptors, and therefore the symptoms get better. And this is a key distinction between Lambert-Eaton and myasthenia gravis. If you do the Tensilon test in Lambert-Eaton, you will see a mild improvement in muscle function. Basically, administering edrophonium leads to some increase in acetylcholine in the synapse, and this will lead to more contraction. But this is much less effective than in myasthenia gravis. In myasthenia gravis, the Tensilon test can completely reverse the symptoms. All you see in Lambert-Eaton is a mild improvement in muscle contraction. The main way to treat Lambert-Eaton is to treat or locate the underlying malignancy. So sometimes patients who have a lung tumor present with this syndrome. What you need to do is image the chest to identify the lung tumor. There is a drug used to treat this. It's called guanidine. It inhibits potassium channels in neurons. So by blocking potassium channels, you make it easier for the calcium to trigger acetylcholine release, and that leads to more acetylcholine release. I think they're unlikely to ask you this on your step one. I'm just pointing it out so you know this. The more important thing is to know how to distinguish Lambert-Eaton from myasthenia gravis. And to help you keep the two disorders straight in your mind, I've made this summary table. So the cause of myasthenia gravis is antibodies against nicotinic acetylcholine receptors. The cause of Lambert-Eaton is calcium channel antibodies. Muscle use, repeated muscle use worsens myasthenia. That's fatigability. It improves muscle function in Lambert-Eaton. Eye symptoms like diplopia are classic for myasthenia. They are less common in Lambert-Eaton. Proximal muscle weakness is rare in myasthenia, but it's a common symptom in Lambert-Eaton. In terms of the autonomic nervous system, symptoms are absent in myasthenia gravis. The problem was with nicotinic receptors, so you shouldn't see any issues with the autonomic nervous system. In Lambert-Eaton, however, autonomic symptoms are common. That's because this affects calcium channels on presynaptic neurons. Those calcium channels are found not only in motor neurons, which innervate muscles, but also in neurons of the autonomic nervous system. And then finally, if you perform the Tensilon test, you should see complete symptom reversal in myasthenia gravis, a very dramatic effect. You see only mild improvement in Lambert-Eaton. And that concludes our video on the neuromuscular junction.